Good morning, everyone, or good afternoon if you're in the East Coast. My name is Arundhati Parmar. I'm the editor-in-chief of MedCity News. I wanted to begin by talking a little bit about MedCity News in case you're unaware of who we are. We were founded in late 2008 to cover innovation in healthcare. We are a national publication drawing nearly 2 million page views a month. We cover biopharma, digital health, medical devices, diagnostics, as well as hospitals and payers in the context of the industry's overall transformation. We also host conferences focusing on investment, population health, precision medicine, digital health, and patient engagement. We accept contributed content through our MedCity Influencers program. Okay, I'm having trouble moving. All right, we also host podcasts. We just launched it recently during the pandemic because we felt like every entity, whether it's business or each of us in our personal lives, we've had to pivot. So I wanted to get a chance to talk to people that are sort of leading the charge in how this transformation to healthcare will come at this critical point. Again, I apologize, I'm having problem with moving the slides. Again, you can contact me at aparmar@medcitynews.com, and we can review the suggestions that you have for guests that you think would be great to have on the podcast. I wanted to say a big thank you to our sponsors, JP Morgan, Unity Point Health, BioEnterprise, and TriNet. We had a special presentation from JP Morgan that is up on our website, and you can go and view it. We had a conversation with Pamela Allsworth, who's the managing director and head of VC coverage at JP Morgan, and she's shared a very interesting presentation on deals and deal making, and also shared some really great advice on how startups can survive this crisis that they're in. A big thank you to MHIN. MHIN is a nonprofit organization comprised of 50 plus active healthcare investment firms with offices throughout Middle America. So Dennis Deppenbush, who sort of leads the organization, has been a big partner of ours and big supporters of MedCity. And then he'll be moderating a panel on Thursday. So be sure to tune in for that. Today's panel is tackling digital health in the age of COVID-19 and beyond. We have a great panel, as you can see. It'll be moderated by Mike Sutten, who's the Chief Digital Officer for Innovaccer. Aaron Martin, EVP, Chief Digital Officer of Providence St. Joseph Health, is a panelist. So is Roberta Schwartz, EVP and Chief Innovation Officer of Houston Methodist. Eric Spaulding, Director of Digital Customer Experience at Highmark Health. And last but not least, Prat Vemana, Senior Vice President and Chief Digital Officer of Kaiser Permanente. I wanted to introduce each of the speakers today individually. So Mike, in his role, guides the company in its mission of creating a connected care continuum through comprehensive patient records. Before joining Innovaccer, Mike served as Chief Technology Officer and Senior Vice President at Kaiser Permanente and led initiatives on analytics, cloud, data storage, and mobile technologies. Aaron Martin, he is responsible for digital and marketing for PSGH. His team is also responsible for driving innovative new programs that improve convenience, lower cost, and improve quality. Aaron manages Providence Ventures' $150 million fund, which invests in early to mid-stage healthcare technology companies. Roberta Schwartz, in her role as EVP and Chief Innovation Officer for Houston Methodist, Roberta is responsible for advancing and expanding the hospital's digital innovation platforms, including telemedicine, artificial intelligence, and big data. Prior to joining Houston Methodist, Roberta worked at Mount Sinai School of Medicine in New York and for the government at CMS. And then we have Eric Spaulding, who is the Director of Digital Customer Experience with Highmark Health. In this role, Eric focuses on bringing innovative capabilities to customers that help them build greater health regardless of circumstance. He brings nearly 20 years of deep experience in design, innovation, IT security, product strategy, product development, brand strategy, and lean startup in a variety of domains, including healthcare, fintech, autonomous transportation, and food design. So with that, I wanted to send this back to Mike, who will conduct the discussion, and then 40 minutes or 35 minutes into the discussion, we'll open the chat to questions from the audience, which I will moderate. Mike, please take it away.
All right, thank you very much. And I'd say great picture, Eric. You look happier than all of us in photos. But anyways, thank you very much. And as you see, we have a fabulous group of panelists on here with a lot of deep experience in digital technologies and in healthcare. And I guess I wanted to start out with the first question to Roberta, and I'll ask all the panelists this, is that, you know, the Chief Digital Officer, Chief Innovation Officer roles are fairly new in the healthcare space. And so I guess my question to you all is, in your organization, what is the role of, you know, your role in that organization, and who are the primary beneficiaries your organization is looking for you to respond to? And I'll start with Roberta, because she has the longest tenure of all of us in kind of the healthcare space. So Roberta?
So it's an honor to be with everybody today, particularly this panel, which is really an esteemed panel that you've gathered today. When you look at it, and apologies as I switch views, I'm now, you're right, 30 plus years into this field, and I actually have the opportunity to have a foot in each camp. So in an operational role, I still run our Texas Medical Center academic organization, and then I serve as our Chief Innovation Officer. And so I've been able to kind of maintain two different camps. In my innovation role, I get to be the evangelist for digital technologies and new ways of doing things, and really saying, is the traditional way that we've always done something the best way to actually do it? And when you really look at the technological revolution that's happening in healthcare, you say, do we really have to have a call center anymore? Is a call center necessary, or can this replace, you know, my call center? Do we have to, the wave of telemedicine that has just swept us because of COVID has really said, okay, we don't need to do things in traditional office visits the way we did it. Now we can change it. But the nice part for me is then I get to step back into the operational role after we revolutionize something, and that actually have to deal with the implications of revolutionizing it. So I think it's both a role that helps gather the troops to inspire people that there may be a better way to do things, to evangelize it, and then to operationalize it.
That's great insight, Roberta. Prat, being the newest person to the healthcare field, what is your role in the organization, and who are you out trying to serve within Kaiser Permanente?
Thank you. Thanks, Mike. And pleasure to be in such a good company as well. Last 10 years, I've been leading digital transformation within the retail space, and prior to that in different industries. So coming into healthcare, I feel like I'm fortunate to come into Kaiser in many ways, because they generally say, drinking from fire hose. This is kind of like multiple fire hoses, right? So whether it's payer, provider, facilities, operations, supply chain, the back end, pharmacy, so you got to get up to speed in every possible way. So my role is structured, really well, actually. I manage all the way from strategy, product management, user experience design to engineering for all things digital, especially consumer focused, for key stakeholders, consumers, clinicians, employee brokers, as well as employees. So we look at that as a, digital acceleration for those key stakeholders, and what does that look like? My other part of my role is also the technology modernization. Whether it's cloud modernization, enterprise architecture, things that go along in terms of paving path for the future. Fortunate to have an amazing blessing through COVID. What we were able to bring in is that really very different key stakeholders aligning on capabilities that required acceleration in many ways. What digital would have, I don't know, it would have taken many months and years to have a conversation on. we were able to put that on the table right away with the COVID-19 right in the forefront. So I have a broad background, but really fortunate to come in a right role within a right organization.
Okay, thank you, Prat. Aaron, I guess you also come from retail in your background there. How's your role evolving at your organization?
Yeah, I think so. I've been at Providence. I will have been there 7 years in January, this upcoming January. And when I first got to Providence, my role was pretty unstructured. I think I had the title of strategy and innovation, and so I didn't even know what that meant. And so what I did is I looked around, in other industries, and I also kind of looked at, our situation as being an incumbent, having come from a, very aggressive innovator and disruptor, and said, well, if I'm joining an incumbent, what's the first thing I should think about? And the first thing I should think about is what could kill us as an organization first. And for us, being a, mission-based nonprofit, we're in a cross-subsidized model. So we've got, our commercial patients or, our private insurance patients fund our ability to maintain our mission with Medicare and Medicaid. And so if we lose that business, we're out of business. And so then I looked at that population and I said, well, what do they look like? Well, they look like kind of everybody that's probably on this call right now, which is, middle and upper income, highly digitally engaged, or wanting kind of, personalization, the consumer experience, convenience that they see everywhere else in their lives, except for healthcare and possibly government and education. And so then I kind of looked around, okay, what role would probably make sense for me to kind of take on within the organization to address that issue? And it's the chief digital officer. So if you go look in other industries, with the chief digital officer's main role is to convert pretty much an offline, in our case, highly unengaged relationship with consumers and with patients into a highly engaged digital relationship with patients. And so move them into digital, but also engage them continuously. And if you look at healthcare is in a very, very bad situation from an engagement standpoint. We typically, on average, we'll see our average patient 2.5 times a year. So what we're doing is we're building, making it easier for consumers to transact with us online. That's step one. Step two is create an engaged experience with them. So that's what a chief digital officer's role is. If you look outside of healthcare, and we kind of brought that in. The other part of what I do is I run our venture fund, and so that goes beyond just kind of the supporting the chief digital. Basically the digital agenda, it moves into clinical and other areas as well. So we have a $300 million fund now with 17 portfolio companies. A lot of them are focused in what we call our convenience, personalization, and access mission in digital, but a lot of them are, purely in kind of the clinical space, et cetera. So that's a kind of a real quick go around in terms of what me and my team do.
Do you think you're using your digital experience to attract and retain members?
Oh yeah.
Is it?
Yeah. So we launched, pre-COVID, we launched a platform we call DexCare it'll be our third company spin out. And, we're gaining share in all of our markets in PPO and in the PPO space and the commercial space. And, the thing I always kind of talk about with that platform is, we're now in the high 90s in terms of NPS. 30% of the patients coming into that platform are new to us. So very kind of, we're gaining share within our markets from a PPO standpoint and from a commercial standpoint. So yeah, absolutely.
Oh, that's great. Eric, how about your role at Highmark? And by the way, you win the best background award in this panel.
I'm going to be forever known for my background. So it's interesting. So I think I'm the one person who's not a chief digital officer. And it's interesting because we're actually in the process of examining what our digital posture is and how to align. And so I think it's interesting for me, my background in design, I feel like digital has many nuances to it, like the word product does, right? And so you have tech-leaning product folks, you have business-leaning product folks, you have design-driven product folks, right? And so kind of the org you build is based on the lean of the person in charge. And so one of the things that I've really appreciated getting to do is bring that point of view from human-centered design to say, if we're to lean with design, what does that look like? You know, one of the things that I'm seeing and that I'm working and building is a perspective around the chief digital officer to be a bit of a magnet and drawing in the right discussions and the right folks into those discussions to ensure that it really isn't heavily necessarily weighted in design or product, but that all perspectives are being leveraged because we've got a handful of folks who've got deep experience, and we're doing a bit of work now to say, let's bring those to bear and understand what does digital look like for this as an organization. But I think for me, a big part of that is being that voice of disruption as discussed here, to be able to say, you know, are we taking an honest look at who is out there and what's happening? What are we afraid of? What are we excited by? And how do we get excited by the things we're afraid of? Begin to build those into our process and make that part of our mission.
Yeah, that's great. So Prat, you were the first to mention COVID-19. So let me ask you, so what are some of the learnings and some of the big initiatives coming out of either part of the plan that you've already put together or in response to the pandemic? Or what are, you know, as a chief digital officer, what are some of those big initiatives that Kaiser Permanente and you are moving forward with?
Yeah, no, I think the both sides, both how consumers adapted to telehealth and virtual care, it just accelerated quite a bit, right? I mean, you know, earlier we used to promote telehealth, or, you know, it was an initiative. Now it's here. I mean, it's just like, you know, just got accelerated. But the other side is also important, you know, from a care team perspective, both physicians and the care teams, you know, how they were able to embrace and adapt. I think that's also, they got thrusted into it by necessity as well, right? So that means, you know, the both have to come up to speed in terms of not only adapting to the newness, but also, you know, what it means to have a high quality consult and follow up, and what modalities matter to what, things of that nature. So, you know, that was actually a big one. The second one I would say COVID-19 has accelerated is collaboration among, you know, different parties, right? So earlier, you know, for me, you know, every conversation required a steering committee and a discussion and whatnot, right? So when I think about what COVID-19 has done is that, like, people were leaning more towards speed and execution and ability to have progress over perfection, right? I mean, the ability to actually have that speed and agility. So I think the collaboration is another big one that we saw is a gift from COVID-19. We still have a lot to learn on where we need to go, but I think, you know, those are a couple of areas. And then the third piece I would say is technology. I mean, we cannot underestimate the, you know, what it needed to get to serve at the speed and the scale that it needed. You know, a simple example is, you know, our API volume went from, you know, when I look at our middleware, it went from 1,800 API requests per second to 3,800 API requests per second, right? Just so if you don't have the scalable architecture and, you know, and the underlying structures for it, you know, I don't think we could have surged and throttled and supported the need, right? So having the right infrastructure behind the scenes, ability to actually have the right architecture was also important. So certainly, you know, the behavioral shift, you know, collaboration and across the organization, and collaboration also requires, it's just not, when a consumer is experiencing digital, there is care delivery team that's actually supporting it full on, care team supporting it full on, a health plans team supporting full on, IT operations. I mean, you cannot underestimate that. So it takes a village to deliver what it took, and, you know, we had amazing people doing that. So those are the three aspects, Mike, I would say. Yeah.
All right, thank you, Prat. I appreciate that. I have some familiarity with that volume you're talking about as well. Hey, Eric, how about you? What are some of the things that you're taking on now that, you know, kind of, you know, we've seen what COVID has done to us, and what are those big initiatives you're banking on at Highmark?
One of the biggest really is the work we've been doing around chatbot and self-service. We've always been focused on self-service. So the group that I lead, the Atlas Labs, is an exploratorium and really focused on our customer framework, customer experience framework. So really being able to deliver tech that helps our customers know what they're going to owe, where to go, and what it is they need to know. So we've got a strong framework that we're able to build within. Chatbot is something we've been building up now for several months, but with COVID, it allowed us to flip the switch very quickly. We were working in partnership with CDC Foundation and Microsoft. We launched a symptom checker. But the big thing for us was really being able to say, okay, what are the kinds of things that our customers need to know about what's happening in the world, and how does that impact their coverage or opportunities that we're providing for them, right? And so it was great because, to the point of speed and agility, this is something we've been plugging away at, but it was this pandemic that allowed us to take this further and say, okay, we're going live with this. Being able to incorporate Google Trends data to understand, okay, we have an opportunity in that where we sit geographically, Google Trends is about 7 days ahead of us. So we can get ahead of what our customers are reasonably going to ask, begin to building dialogue flows, understanding impacts on call centers, and being able to be a week ahead of rerouting so we could reduce the strain on call centers and make sure we were getting people to the right answer. I think the other thing that brought about is we've talked a bit here about, trust inherent in our industry and how our customers trust us. It was really interesting once we flipped this switch to see how customers began to trust us. So they've got this information out in the world anyway, but they're coming to us for verification. And it offered us a moment to build a different kind of relationship. And I think to that point, how do we keep this going, moving it forward, is how do we leverage that trust? How do we show up in new ways and help serve them now that we've begun to build a bit more of that? I think the other thing I'll just say is we've done a handful of partnerships were really critical for us here. For us, care extends beyond just the person. So we did some partnerships with a company called Aunt Bertha to make sure that community services were available and put in the path of our customers. We looked at partnerships and engaged with Mercy ICU for virtual care, things like that helped us extend our footprint for some of our smaller clinics that maybe had a more rural footprint and didn't have as much coverage. We were able to then augment that, right? Open up beds and open up availabilities for folks.
Yeah, that's great. I'd never imagined the day where a chatbot would actually be a welcome thing. I actually enjoy engaging them. Microsoft's certainly done and others have done a fabulous job in that. Roberta, how about you? What were some of the big tech initiatives you took on, from the learnings of COVID?
I think one of the things that was amazing to me was I remember in the room, we gathered all of our folks who are involved in the Center for Innovation and Technology, and as well as a number of our IT partners, and just laid on the table and said, okay, tell us every technology that we have that can be turned towards COVID. And it was more of a, okay, just give us all of the ingredients we have and tell me what use they have for what's going on today. And we don't have time for new stuff. We don't have time to kind of bring in everything. But what we realized was all of the ingredients that we had sitting out there could just pivot just a little bit to really help us with the crisis that we had. And I was amazed at how quickly we were able to take, whether it was MyChart bedside, get up and going on, iPads in the rooms for virtual consults to, flip that to telemedicine, to go from 5% of our visits being telemedicine to 80% of our visits being telemedicine in the span of weeks. How quickly we could virtually train everybody, chat bots, symptom checkers, everything that we had already. If you had a robust set of ingredients, which everybody on this teleconference really already had, which is why you're talking to us, right? It's we already had that set of things, and then we could just pivot them to a new level. I think what all of us, maybe it was just me, didn't realize is how quickly adoption could happen and how quickly you could go from a 5% to an 80% on telemedicine. The question that all of us have is, when that dust settles, what is the level that's here to stay for good? Like, what has fundamentally shifted in the period of 8 weeks? So I have chatbots like everybody else, right, on 20 lines that I never had them before. Are they going to stay? The virtual ICU, as COVID comes back down the other side, is this permanent? Do people accept this as a permanent new way of being? Or do they say, well, that was then, this is now? Telemedicine, all the doctors that realize that they could now do 3/4 of their visits on telemedicine, do they think that's here to stay, or are the visits coming back in? And where does this all settle out? So I think the amazing thing is the technologies were all there. We just had to adopt them from both sides, both the health system and the provider point of view and the public. And now we've had a seismic shift And we need to understand when the dust settles, where are we going to be?
Yeah, I think that's a great perspective. I mean, Aaron, so what's your feeling of, kind of what are those things that are going to stick? You already had a pretty strong digital presence. So like, kind of what's next?
Yeah, I think, one of the things that that we're kind of working on is a few things. One is I don't think things can stick or accelerate without health systems moving to risk very, very aggressively. So I think at the end of the day, so, I was, chide Prat, he's already there. He's at the promised land, go with God. The rest of us kind of are, on the provider side, we have in Oregon, a plan, a health plan, but we've got to move more aggressively into risk, because if you just do the math, there's a couple of things. People focus on kind of the friction within kind of digital in terms of, for instance, we're on track to do probably 5 million virtual visits this year, right? That's a massive number, right? The problem is it's still loaded with friction for both the patient and the provider. So that's one block of work that we've got to do. But even if you do the math on that, and you assume the same reimbursement level, which would be a false assumption in fee-for-service, the productivity rates, we're going to make burnout worse, not better for providers, unless we move to some form of taking on risk and capitation. Because basically, we did some math and we said, these providers are going to have to do anywhere between 3 to 4 video visits an hour to kind of just maintain their income on a fee-for-service RVU basis, right? And that is just inhuman, right? We should not have, primary care physicians, doing kind of fee-for-service work. And so we've got to get to kind of capitation very, very quickly to prevent, obviously it's a better model, which was really clearly demonstrated during COVID, but then also to prevent a physician burnout and over-treating folks. So I think that's actually the core issue. You'll see us kind of be very aggressive in that space. And then also be very aggressive in terms of taking all the friction out of the process for online scheduling, virtual visits, and then also creating an engaged experience around people's health.
Yeah, I think that's great. I mean, in my role, I get to talk to a lot of CIOs, CEOs of health systems. And I think we're all feeling the Zoom burnout ourselves. And can you imagine a physician that has to do that day in, day out? I couldn't imagine. So, Prat, how about some insight in Nirvana on kind of what's your next big tech, foray you're going to move your environment into?
It's a good question to say, what stays and what changes, right? So if you look at historical evidence, when you look at financial institutions that went through a crisis few years ago, right? What came out on the other end is much better products, much better services, really good disruptive digital banking, the ability to have mobilization between, if you have a bank account, it used to, if you remember, it's only savings and checking, but all the way now you can do mortgage, you can have investments. I mean, there's a fluidity around what it means. In many ways, health system, this is our opportunity. I think this is our opportunity to take a step back and say, how do we make it whole for the members and the patients? How do we make sure that, we talk about care continuum and talk about different touch points, but this is digital and physical and clinical coming together in in a very good way. So that's the exciting opportunity here. Most health systems, when we, historical evidence shows that a launch of a digital capability really meant that, you launch its own website, its own 800 number, its own app, and, that's how it went. And, information sharing between specialties, working as a team, things of that nature was much more manual and physical. I think digital could change a lot of that, bringing it together. So what next is really, making it easier from putting the patient or the member or the consumer in front of us, saying, what would it make easier for them? How do I organize the information in a way that they can consume and manage their lives, right? And then how do we make sure that, when I'm moving between systems, it's seamless, as seamless as like, moving money between two accounts, if you will, right? So what does that look like? The interoperability that coming in is going to help in a great deal. And also really, a lot of this depends on how well we do it as a health system across the board. Few bad experiences are going to burn everything out. How do we make sure that, it's not like there is consistent experience across the health systems as we move between the cares, between settings, actually, right? So lot riding on it. From a technology perspective, I see personalization, AI, ML, leveraging data for actually truly helping the member, things of that nature coming to the forefront. But to Roberta's point, it's the other side, the clinicians also, right? How do we make sure the caregivers are taken care of in this, and can the technologies be applied? So a lot can be done. I think we need to prioritize, make sure that we have the right things that we focus on, and really create the right experience. I think it really comes, the better the experience is going to get, the better the adoption is going to be there. Otherwise, I think before we know, if there is such a thing called COVID-19, post-COVID, I think people will settle back in their habits, and any goodness that came out of this would not stay. So.
Yeah, very good. Yeah, and I appreciate that comment about, we need to be purposeful in how we move forward, because the mistakes, consumers have long memories and physicians have even longer memories. And so, we need to do this right as technologists. Thanks, Prat. How about you, Eric? What do you see coming out? What's your crystal ball on what's coming out of this COVID event?
So I think to echo some of this, one of the things that I'm seeing is the need to play in the problem space more than the solution space for a while, right? And so what's come at us is something, there was no single bolt, there was no one thing we could do, right? And so it forced us to take a harder look at the actual problem space. I'm now seeing that happen across the board in terms of, okay, as we look at partnerships, as we look at projects and directions we were planning on taking, are these the right ones? Do we have a moment to take a step back and ensure what is the experience we're actually trying to build? And then, really tracing back, where did that come from? How did we assess it when that came in? Do we believe this is still the same world that it was in 2, 3, 5, 6 months ago? And how do we then make sure we're building the ground underneath us before we move forward? So definitely seeing a good bit of that. I think the other thing is, one of the things we've been pushing on is this willingness to look across assistive and agentive technology, right? And understanding some of the legal and kind of the hurdles that you run into. I think the financial example is a great one there, right? When you start thinking about, okay, things that we're doing to augment what somebody's trying to do is one thing, but when you start doing on their behalf, we get into a very different space where we're trying to create solutions that there's something acting on their behalf in the background, and that's a new world for us to get into. But we're also seeing, given the way the world has changed, what are the kinds of things we can do in the background that can help tee up for somebody things that they might need to expect during their day based on a specific kind of condition, for example, right? How do we engage them in new ways that we've got this trust to show up? And I think the point of, patients or customers, members might spend 5 days out of the year with us. And so what are we doing for them the other 360 days? There's reading a really interesting discussion that I had a product at Indeed who was talking about, we design for 5 days every 3 years, right? And so really thinking about that in those moments, what are we trying to do for them and how are we trying to set them up for when we're not face to face?
That's great. Hey, and Roberta, I guess one of the things I'm curious also about kind of what you guys are thinking about from, some of these enabling technologies, perhaps home care and those types of things post-COVID. Are you, what are some of your thinkings on this? And then we're going to take, we promised we'd take time out for some questions. So after Roberta's, we'll open up for some questions.
I think that there's a lot of different locations in the direct-to-consumer space that are helpful in terms of the follow-up. Actually, one of my favorites has really been the work we've done in the care pathway space. And we had enabled probably 30 kind of solid care pathways that get in touch with people, both one-directional education and bi-directional information back to us, about 30 of them before COVID on a lot of our surgical as well as heart failure procedures. We actually pivoted that technology and started to keep in touch with our COVID patients using care pathways, both those that are discharged from the emergency room and those that are discharged from the hospital. We've seen well over, in most of our care pathways work that we've done, well over a 50% reduction in readmissions back to the organization, including so far our COVID population. So we did find that as we're able to keep in touch from with individuals and kind of have this support mechanism with our patients, that we're able to actually both keep them out of the hospital, reduce the length of stay, and get them the information that they need without even having to call in or discuss things with a virtual doctor. So what we find is that if they report certain, I'm still have a very high fever, or I'm still having trouble breathing, we get in touch with them before they need to get in touch with us. So I do love the technology. Again, just pivoting it into a new space has been particularly fruitful for us.
Yeah, that's great. In fact, I just add, I was speaking to a CMIO of a facility that, is highly rural patients and members. And the mere fact that they could link in other people to the telehealth visit and bring in family members that were living across the country was something new that they'd never done before. So we never even thought of that as a possibility. So there's a lot of new options. So with that, I'd like to turn it back over, and if there's any questions for us.
So as we wait for the audience to gather their thoughts and submit some questions, I thought I'd ask a question first to Aaron and then to the rest of the panel. Aaron, startups have long complained that, it's hard to work with hospitals. You guys take a long time in approving things. How did that change during the pandemic? And is there a different way that you are interacting with startups, investing in them? I think you have to unmute yourself.
Yeah, hey, sorry. For some reason, Zoom was being a little bit too helpful. So I think, most of the work, just to kind of, echo what Roberta was saying, most of the technologies that we deployed for COVID were technologies we had invested in over the, past few years. It was just too, like Roberta was saying, it was too emergent to kind of, have a brand new relationship with a brand new startup, understand that company. I mean, just too much is at stake. And so what we found ourselves doing is taking platforms that we had developed and then kind of, as Roberta had talked about, pivoting them probably 20 degrees in some cases 180 degrees. And we basically built, kind of a 3-stage platform of, self-assessments. We used a framework that we built for, our bot framework called Grace. And we brought in technology with Microsoft HealthBot, to kind of address kind of the self-assessment piece of this. We launched, we used our platform that had been powering our same-day kind of retail business called DexCare, and used that for kind of kind of assessment. So video visits, we saw that spike kind of day over day, 30x. And the story I'll tell there is most of my engineering team comes from Amazon, and I used to complain to them about how they were over-investing in scalability and we need to do more feature work. And thank God they didn't listen to me, because my perspective is we'll never see this kind of volume you guys are building for in our lifetimes, just given the kind of the curves of adoption we're seeing. And boy, was I wrong. I mean, we saw huge surges. And fortunately, the team had kind of ignored me and kind of built for scale. And then the third part of it is, so once you kind of self-assessed, we determined there may be an issue. We have a nurse practitioner see you over the internet using DexCare. The last piece was what were 2 technologies. One was a prescribing platform that we had incubated called Zelth, and the other is a company called Twistle that allowed us to prescribe for patients that were not sick enough to admit, but were PUI, patients under investigation, prescribe this app called Twistle that allowed us to check in with them 3 times a day, scalably, very, very simple, approach, which was we sent out a thermometer and a pulse ox. We asked for, them to kind of measure themselves 3 times a day. If somebody started to decompensate, then we would see them with a video visit. All those technologies we had used for completely different, use cases pre-COVID. And now the weird thing is that we're a big health system. The Pacific Northwest is largely settled down a little bit in COVID, but we're also in Southern California. We're seeing that start to spike. And so now the platforms are being used in both use cases simultaneously. And then the last thing I'll say, which was, really, really interesting, is we brought all of our businesses online. So now the navigation challenge is massive because we can see you in about 6 different venues for a whole bunch of different patient complaints. And so how do you navigate the patient to the right venue of care? We can see you in primary care, urgent care, retail, video visits on demand, scheduled video visits. There's a panoply of different ways that we can see you now. So how do we make sure you get to the right location and have a good experience? So that's kind of the problem we're working on right now, is we went from too little to way too much, right?
So there are a couple of questions from the audience. I'll take one, and Eric, maybe you can sort of address that. The question is about the direction that remote patient monitoring is going. What capabilities will set RPM companies apart in the flood of new telehealth companies?
Interesting. Well, I'm not sure I'm the best to comment on that, but one thing I would talk a bit about is, echoing what was said before in terms of, we had this availability prior to COVID, and it was more to expand the abilities within rural units. I think now understanding how that's worked and, how that partnership has worked, we're able to take those learnings and say, okay, so what other footprint might we begin to try to expand with that? And again, part of that is looking at some of the information that we have around social determinants of health. Where do we know that we have a lack of beds, right? Where do we know that we might be able to beef up some of these abilities? So to me, it's about understanding, okay, so what have we seen work in this case now with the smaller organizations, and saying, okay, who do we feel might be next that we would want to begin to try piloting this out?
Okay, Prat, I'll repeat the question and I'll have you address it as well. What are your thoughts on the direction remote patient monitoring is going, and what capabilities will set RPM companies apart, given that there's a flood of them?
It's a great question. I think it has to be intentional and purposeful. I think that's number one, right? So we got to understand what the technology is and what it's used for, and need to make sure that you can measure the patient outcomes and it's actually significantly improving before we deploy the technology for the sake of deploying technology. I think a good example that we had was cardiac rehab program, where our care delivery team has working with our amazing physicians, been at it for a few years now to test out and make sure that post cardiac procedure, from a rehab perspective, if we fit them with a smart device and a wearable device, and and also have a two-way communication on what do we understand, what do we have to react to. It was very clear that the patient outcomes was like amazing. And 2 things happened. One is the adherence went twice because now they understand that somebody's actually caring about me, monitoring and making sure that I'm healthy as a patient, right? On the other side also is that by doing small things and tasks and whatnot, that interaction, we were able to actually reduce the readmission rate significantly, and also the satisfaction among the patients on being able to use is actually very important. They were able to recognize the importance of it. So when I think about any one of these remote monitoring devices that we are deploying, it has to be purposeful intent, clear intent. Both sides understand the expectations, so that it's just not the device it's there, but it's transmitting data back, and then there is somebody reacting to it actually. Right? So I think that if we do this thoughtfully and go, it's one of those areas where speed has to be considered in context to the patient outcomes, and I think the outcome will be really, really good.
So I have to thank my husband for sort of alerting me to this story, and maybe Aaron, you and Roberta can take this. He read a story to me the other day where this Israeli company that I think we're aware of called TytoCare that makes connected devices. They are making, they're sort of designing physical exams rooms in the patient's home. I thought it was a fascinating and extreme sort of example of home health. So I wonder what your thought was on that. Are we going to see a point in time where there will be physical exams happening inside people's homes?
So
Erin?
happy to start.
Yes, Roberta, go for it.
So for those people who don't know what TytoCare is, I would encourage you to go onto the internet and look it up. They have a very nice video. But actually, we're one of the partners working with TytoCare. It's an exam-in-a-box. So basically what you do is that you can take this home. Believe you can get it at Best Buy, you can get it at certain places like us, who have them. And it's a stethoscope and an ear look and, kind of a look in your throat. And you basically hook up to a computer. You can actually send it to a doctor while you're doing the exam, or you can send the files in advance. Probably equally as important is they have TytoCare for Home, which is kind of this exam-in-a-box. They also have TytoCare Clinic, where a lot of the workplaces now, occupational medicine, want these clinics at the workplace. And it's attached kind of to almost an iPad technology that can hook you into a virtual care visit. The visits from home are getting much more sophisticated. It's not just hey, open your mouth and look in the iPad and look at the camera and try to do it. They're getting to the point where the sophisticated type of examination that a doctor would do now can come across in a digital file. So I do think that this remote monitoring, and we've talked a lot about to home, but if you think about it, it also can happen within the hospital. We're looking at different technologies that can kind of continuously monitor people when they're in the hospital and send those files to doctors. Working with a company called MIC Sickbay, who's monitoring all of the data behind the scenes and starting to alert either our virtual ICU doctors or other doctors about changes that are happening in the patient's condition. So this remote monitoring, this combing of the files, combing of the exams, and combing of the data is really starting to come of age. And that's where, people are starting to talk about how we mine this big data to kind of alert people. So I think there's multiple ways to really think about big data, big tech, digital files getting across to physicians to do a more sophisticated exam than just, hey, I'm going to get on and look at you.
Erin, you want to take that?
Yeah, I think it's a continuum. So based on the acuity and the severity and the complexity, right? And so if you see right now in primary care, I think we estimated probably 40% of primary care visits could be taken care of through a straight ahead video visit, right? And so what I challenge my team to do is, okay, so how are we not, so your goal is to make sure that if there is a mandate that comes down that we have to shut down all of our primary care clinics, which really kind of happened during COVID, how would we deliver care for the other 60%, right? And if you think about it, the model already exists today. And yes, having kind of the patient kind of self-administer is definitely probably, let's say, another 20%, right? Where, a patient who has some competence in kind of technology could deal with that. But the rest of it is already being done today, and it was pre-COVID, which is funded by, and it was funded by Medicare. The issue was Medicare had a restriction on it had to be between two clinical sites, right? But if you think about how telestroke works in most situations, is what I'm referring to. You have a neurologist on one end looking at somebody who is exhibiting stroke symptoms, hundreds, if not thousands of miles away in a community hospital, who is being examined at the direction of the clinician on the near side, right? By a nurse, by an RN, most probably in the ED. So take that same model and just extend it to the home, to where you've got a lower licensed individual conducting the physical exam, and you've got the primary care clinician in kind of a central, hub conducting these exams. So if you kind of like break down the problem, I think it's true in specialty as well. You could probably get to the point to where a clinic visit is pretty rare, where we're getting patients to kind of come in. The problem is you need health systems, again, see kind of my first comment, to move towards risk, because we will start doing those types of things when we're paid to take care of a patient population versus paid per activity, right? So I think it's totally possible to get rid of primary care clinics over time.
Prat, this next one for you. This is, I don't know if this has happened to you or not, but I'd like you to address this anyway. There's a question from the audience about how some startups have gotten overwhelmed with COVID, even startups that have had large hospital and health system customers. Did you encounter any situation where there was a disruption of service from such a startup? And if so, how did you address it?
So there are startups, there are the technology startups, there are service provider startups. I think, mostly, technology type of startups has been able to sustain the COVID-19. I think what we saw, this was, I don't know, without mentioning the name, but there are some organizations that was a service, also providing the service of, whether it's telehealth or other things. I think they got overwhelmed by, how do you add capacity at the speed that it's required when the inbound is so heavy and nobody expected. It's not, it's one of those things where, in technology, we can, load test 5x, 10x, right? So what does it mean to load test like 5x, 10x from a service delivery perspective? I think that's harder. So we saw that, but I think, most of them recovered fairly fast. But it's situational, and I think, I don't know how much could have been anticipated.
Got it. Eric, there's one from you, and I'm ending the question from the audience just a little bit. There's so much data that's being shared right now. Many of the barriers to interoperability have sort of magically disappeared. HIPAA obviously has been, benevolent, I guess, to use the term. But this has also led to an attack of the threat surface, as I understand it's called in the world of cybersecurity. I'm wondering if you have any thoughts on how to deal with patient privacy at this time when there's so much collaboration happening.
Yeah, so I mean, we've actually made a pillar of our Atlas team that privacy and consent is a core group. So we have active participation with CMU, with local universities in this space. So for us, a lot of it's about context setting. A lot of it for the customer side is making sure we're incredibly explicit in what they're signing up for, right? Whether it's a bot, making sure that at every single point of digital interaction, they know exactly how to revoke consents. That's a huge part of it. I think the other thing is really working and partnering with our legal and privacy team to look at legislation that's coming out, even things that aren't touching on us now, really being able to do the due diligence to say, when do we reasonably expect that this is going to be something that's going to affect us? And let's get started now, right? So really wanting to get ahead of what these various bits of legislation are saying. As the team that owns kind of our member portal experience, chatbot experience, these digital touch points, it's every bit a part of the UX team and our product strategy group to make sure that we are in constant communication, whatever it is that we're either thinking of launching, preparing to launch. We've done our market and ops readiness, and privacy has been a large part of that. And then making sure we have the right feedback loops associated with our test population so that they understand at every point, how do I then go about changing if I need to?
And then Mike, I had a question for you. Does the pandemic sort of accelerate the move to value-based care, given that hospitals now have to contend with loss of revenue on many quarters? What have you seen so far?
Well, a lot of it kind of leverages the point Aaron was making. A lot of people are thinking about taking on that risk, as because I think they see that as a better model coming out of the pandemic environment. So we've actually, Innovaccer, which integrates data to serve a population, we see a lot of movement towards this space now. And I did have one comment on the security thing is I think, you know, there was a lot of talk about how the regulation on interoperability would, you know, kind of open security surface, but in fact, it reduces it. The move to APIs is inherently more secure than batch ASCII files, rarely which have even password protection on them. I think, you know, the cloud is inherently more secure. If you think about the amount of people that, you know, whether it's Microsoft or Google or Amazon, that is protecting the perimeter and protecting services within that, it is 10 to 20 times greater than any, even Prat's security department, which is quite large. So I kind of disagree with the idea. Oh, and then by the way, we're now asking members and patients if they would like their data shared. And we have never gone to that level before. So sorry, I kind of went off, but I was kind of compelled by that question.
No, I'm glad that you did, because again, I'm a layperson. Journalists have superficial knowledge on a lot of things. So I'm glad you corrected me. On that note, we are at 10:30 here in the Bay Area and 1:30 Eastern Time. So I wanted to take a chance to thank everyone. I know everyone's busy and there's Zoom fatigue, but I am so delighted that I was able to corral all of you to speak. You have great perspectives. Each of you come from very well-known organizations. So thank you so much for taking the time.